All right, so again, I'm Eric Peden, Crows Bashara. So veins of the arm, those of you at this place, you'll see lots of this while you're here. So we think of the veins of the arm kind of like the veins of the rest of the body with superficial and deep systems, right? So we think about cephalic and basilic as being sort of our superficial, but the basilic, of course, transitions to deep later. The other thing I think that's really important to think about with the veins of the arm is that their proximity to the superficial nerves, right? So in many books, this is called the medial antebrachiocutaneous vein, the thing that we think of as the forearm vein, and then it's shaped almost kind of like we think of the brachial plexus, right, with sort of this M configuration, that this lateral one is more commonly called the cephalic vein, and this one this. But kind of realistically, we think of whatever's running over the center of the forearm as being sort of the forearm cephalic vein. But up at the elbow, it comes in close proximity to nerves. The forearm basilic, of course, wrapping around the back side and then traveling up at the upper arm. So nerves beside each one, the lateral antebrachiocutaneous nerve, right? So the lateral forearm, the skin, not a muscle, not a motor branch. And the opposite for the basilic, that you have the medial antebrachiocutaneous nerve, right? So that any intervention around the cephalic vein can lead to some numbness here. Any intervention around the basilic vein can lead to numbness here. Really common. And I think of all the things you do in vascular, you're going to have troubles. I can just guarantee you that. You're kind of entering a field just built on complications, right? And continues to build itself on complications. It's kind of a recycling thing. But the more you set expectations for those and then kind of recognize and manage them, the easier your life will be. And I think the happier you and your patients will both be. So in the forearm then, at the antecubital region, there's a confluence. And as the cephalic vein comes up, it typically drains the three pathways. The upper arm cephalic vein, which you kind of think would be the primary mode, but it's usually not. It usually goes to the median cubital vein over then to the basilic vein. And then there's a perforator branch that goes down to the deep vein system. So important to kind of think about that is then we come up the arm, the cephalic vein comes up and then penetrates the fascia at the clavicular-pectoral groove, and then goes down and joins the axillary vein. The basilic vein, at a variable distance in the arm, will go down, perforate through the fascia, and then typically join the brachial vein, either in the upper third, middle third, lower third, somewhere in the arm, and then will essentially become the dominant outflow for the arm. So we kind of became interested in this because sometimes in doing dialysis access, if you use the basilic vein, it'll do this. It'll join a single unpaired brachial vein and will become the entire venous outflow for the arm. Meaning that if you use this entire vein with a transposition fistula, with a PICC line, something else, it could be the entire venous drainage of that arm. Typically, the arm's pretty forgiving about occlusion of these veins, but if you have an access in that arm, so a dialysis shunt of some sort, that can lead to severe hypertension if this whole vein's been obliterated. So kind of recognizing that variable anatomy does occur, I think, really important. And then moving more centrally, right? So we go from axillary vein to subclavian vein. Subclavian vein then going to join with the jugular vein to go and make the brachiocephalic veins, right, on each side, then superior vena cava, and then return down to the right heart. So let's see. So arterial anatomy, similar. We're going to start at the beginning. You start at the arch?
Yeah, I think I went upwards in the veins and then back down in the aorta, in line
okay.
with the flow.
Right. So axillary artery, right? So after the subclavian crosses the first rib, then you have the axillary artery, typically underneath the pectoralis, right? So when we think about exposure of the axillary artery, the key move when you're asked that is division of the pec minor, right? So splitting the pec major fibers along their course and then dividing the pec minor. That's sort of the sweet spot for getting access to the axillary artery. If you don't do that, it's going to be a struggle to get it above or below. Then it's going to transition down to the brachial artery. And then continue down to the brachial artery until typically at the elbow, although I'll tell you this is widely variable, and at least 10 to 20% of people can have what's called a high bifurcation, meaning that the radial artery can come up as high as the axilla. Right, so kind of knowing that and thinking about that, really important. The more the ultrasound is in your hand, the more you're looking at things, the more anomalies you'll see and how people are so varied. So then coming down and splitting into the radial and ulnar, and interosseous coming off one of the two. More commonly the ulnar, but it can come off of the radial as well. And then continuing on down to the wrist. So the dominant flow to the hand, which one? Radial, ulnar, for most people. Radial, ulnar, interosseous, bular artery. Yeah. What do you say, man? Tommen? The radial. So we do lots of radial artery punctures and art lines and catheterizations, that kind of stuff. You occlude this sometimes. Unfortunately, the ulnar is typically the dominant, right? But important to test that. How would you test? Rachel, tell me. Describe it for us.
I haven't done it, but
Haven't done it, yeah. It's a virtual experience.
Yeah.
That's why you're here, right?
You compress both radial and ulnar and have them and release
And then, so compressing both, having them exsanguinate the hand, right?
and then I guess releasing and seeing if the blood's in
And then releasing one or the other and seeing does the hand pink up or not, right? So you're counting on the fact that both of them are open and that you have a patent palmar arch, right? Palmar arch, typically 2 arches actually, right? So radial coming around and more commonly supplying the superficial, and then the ulnar, the deep, although obviously if it's an arch and connects both, you should be able to connect through both. But important to do that, and sometimes you see the vascular lab doing kind of a modified Allen's test, where they'll occlude one and watch with Doppler flow on the other to see what the flow pattern does, or go out and look at the hand or digital amplitudes, occlude one or the other. Not commonly done, sadly, and some people do get harmed from that, right? Because if they're radial dominant, you put a radial art line in, that can be a real problem for some of these people. And you'll see, I guarantee you'll see ischemic hands in the ICUs in your practice, in your training, and then your practice again. We've got one now where it looks like the person's going to lose, like the medial half of their hand. It's really tragic when that happens. And if it's not recognized early, it's a real problem. And the arteries down here, of course, are fairly small, so it's a real problem. Yep. All right, so brachial artery we just talked about, radial and ulnars going down and then making them to the arch. Where are we here, Alan?
Yeah, on the back. You look. It's a posterior view. Posterior circumflex humeral. It's not a big deal.
Not something we commonly look
Yeah.
at unless we got something cut and bleeding, right? They go over so something. So collateral pathways. So the arm is remarkably tolerant of ischemia compared to the leg, I would say, in terms of occlusion of major branch vessels. So collateral pathways come around the elbow to both the radial and to the ulnar, right? With these circumhumeral branches, I guess. And then back when people have axillary artery occlusion, remarkably well tolerated. Subclavian artery occlusion, remarkably well tolerated. What's not well tolerated is when you get distal occlusion here, that's when you have real problems, right? Because once your branch vessels become occluded, there's nowhere for your collaterals to come down and hit, and that can be a real problem with ischemia and tissue loss. You're much less likely to have patients wind up with such severe peripheral arterial disease they wind up losing fingers. When that happens, it's a really bad sign. So if you have bad enough ischemia that you lose fingers or a hand, your mortality is greatly accelerated, even compared to other PAD patients, which is pretty bad as it is.
Nerves.
Yeah, so nerves. Have we got? Do you go over the nerves or something else?
Yeah, a little bit, but yeah, I would spend time in them here
Yeah.
in relation to exposures.
All right, so when we're doing common arterial exposures and that kind of stuff, cut down for access, cut down for body flossing patients or something like that, we worry about several nerves, right? The common nerves that get injured, fortunately, are the superficial sensory ones that we talked about, sort of the lateral antebrachiotaneous, medial antebrachiotaneous. Again, expectation, if it's set up in advance, you might have a little numbness in this area, not going to hurt you, still can use your hand, should get better over time, I hope, or hopefully kind of go away before, whatever. Then that will be okay. What's not okay is when you injure these, right? So the most common nerve for us to injure, or for us to see that's injured, what would you guess? The median nerve. How's it going to present?
Usually you'll have weakness of the first 3 fingers,
Weakness of the first 3 fingers?
2.5.
So the problem is this. So let's say this person's had some kind of surgery in their arm or whatever, and you've done dissection. You put down a wire to do some kind of really fancy body floss thing, and FEVARs with Dr. Bashara, something like that. So the arm's kind of swollen. Something's not right later. Somebody says, "I think that guy has a median nerve injury," and you're like, Maybe, maybe not. Does he what? So now kind of step through it. What do you think he would have? Can he use his hand? Can he do this? No? Looking for a yes? You're right. You're right. He can do that, right? So why can he do that? Why can you do this?
Because the ulnar nerve.
Because the ulnar nerve's intact, and the grip of the strength is really from the flexor carpial. From the flexor digitorum profundus. So the deep flexors have a one muscle body that's supplied by the ulnar, right? The superficial have individual muscle bellies and are supplied by your median, right? So that's why you can play the piano better with your median, but in fact, gripping something is actually an ulnar deal. So doing this is going to be kind of vague, right? So sensory, what sensory problems will they have? So numbness in the first 3.5, right? So these three, the volar aspect of those three fingers, and then the medial aspect of this. I can tell you that's a little variable as well, but sensory. So I would tell you actually the sensory is going to be the first thing you really find, the sensory. Because if you just do a crude, can you open and close your hand, like have you had a stroke, you're not going to pick it up. What other motor thing though? Opposition, specifically the muscle. And by opposition you mean? Right, so being able to pinch your thumb and your finger together, right? So the opponent's pollicis that lets you bring your thumb up out of the plane of your palm, that's a median function, right? So when you kind of talk about, I want to get one isolated thing that only that nerve does, because there's lots of overlap, right? Just like the palmar arch, there's perfusion from both vessels. Just like sensory, there's crossing of that. There's usually something distinct that you can pick up for each nerve, right? So for the median, it's this. If they can do this, then the median nerve, grossly anyway, should be intact. Doesn't mean some part of it hasn't been injured. Sensation on the index, on the pulp of the index finger, median nerve should be intact, right? The whole nerve has not been transected. Doesn't mean it hasn't been injured or something else, but has not been transected. So ulnar nerve, tough for us to injure that one, thank goodness, unless we're high in the axilla. But median nerve, I would say, much more commonly injured. Injury mechanisms might be what? You could cut it in half. Hopefully not. Travis?
Retraction.
Retraction. Huge one, right? Huge. So if you're going to some kind of reoperative field, you're kind of digging down deep in a big person, you've got the Wheatlander or Gelpies or something in there pulling back. Retraction, probably the most common.
Maybe clamping.
Clamping. Hopefully not. Hopefully you're not just going to bury that, right? But when you talk about like the neck nerves, the most common way the vagus nerve gets injured is because you pass point with the clamp when you're clamping the common carotid, and you injure the vagus nerve that way. But clamping shouldn't be.
I guess just during dissection, injury with the pickup or
Pickup, cautery, something.
yeah.
What about you? When are you going to injure the median nerve?
Using it with the vein and making a fistula to it.
So that's been done. I've seen before somebody sew something to the nerve. It's kind of hard to find the lumen when you're trying to sew those together. If you're really dedicated, you can find some space in it, though. Okay? Please never do that. That's a real bonehead move. And you'll do bonehead stuff. I guarantee it. I mean, every one of us has done some stuff that we're like, oh my God, I can't.
I know.
I can't. You just wonder, you wouldn't believe what just happened to me. That's why we have doors on the offices, right? So we can close and talk about these things. Okay? What about you, man? How are you going to injure the median nerve? Anybody else think about how you're going to injure it? And you may not ever know until the next day, huh? Hematoma. Specifically, if you're doing some kind of percutaneous intervention, right? This stuff is covered by the brachial sheath, right? Is it loosey-goosey? No, it's really tight, right? It's a tight little confined space. And the fascia, pretty tough fascia. So if you do a puncture and there's bleeding, and then they start complaining of nerve problems, and you go to look at the patient afterwards, so your senior says, go look at this guy, he's got some kind of thing, make sure he doesn't have a median nerve injury and hematoma. And you look and you say, arm looks fine. There's no hematoma I can see, but the guy sure enough is complaining of some numbness in those fingers. Faking it, high on crack, seeking drugs. What do you say? Ultrasound, you don't see much. Watch it overnight, all good. Take those in the house. Order one for me, I like them tall and frosty. So the issue is, like I was saying, it's a small, tight space. It takes very little blood in that space to compress structures, right? What's going to get compressed first? The vein. Okay, well, so be it. We got lots of veins in the arm, right? So you might have a little mild swelling. It's going to be kind of underwhelming. The thing that's going to be most sensitive to compression, they've still got a pulse. It's the nerve, right? The nerve. When the nerve gets compressed, it's very unforgiving. And unless you release that nerve quickly, you're going to wind up with permanent nerve injury. That's a bad deal after a percutaneous procedure, right? So high index of suspicion. If they have some kind of brachial axillary puncture and afterwards they start having hand symptoms, that's a real issue.
I mean, that's
Carlos,
probably the
you do
most
lots of
common reason though
percutaneous?
for getting median nerve injury. Usually not surgical.
Carlos, lots of percutaneous brachial stuff?
Yeah, I mean.
High level of anxiety about it?
Yeah, a lot. I mean, I can tell you that's one thing when I do it. I used to do a lot of them. Is I'm always every 30 minutes I'm back in the PACU checking that hand for an exam. Because I mean, you could easily miss it, and then you want to go back as soon as possible just to evacuate it and fix it. So yeah, it's a real deal.
And the thing is, when you go to evacuate it, it's not much blood at all.
Yeah.
Yeah.
I mean, it's,
So
10
let me give you a
cc's or
person-
something. It is not a hematoma like.
Let me
like
give you an
recent.
example. The first thoracic angiograph we did at Emory, we went transbrachial with a 5 French catheter. Thoracic angiograph went fine. We were high-fiving. Guy comes back to the office and said, hey, thank you very much for fixing this, but I'm having trouble using my hand. He really hadn't said much about it post-operatively. We may have blown it off a little bit. It never got better. I mean, we were delayed in doing an intervention. This guy had a dysfunctional arm, and then he started getting neuropathic pain associated with this, which was really difficult to manage. So these are not trivial little things. And one of the unfortunate things is because we are vascular surgeons, we tend to look at the blood vessels and go, hey, not a problem. But there's most blood vessels are associated with nerves, so you need to be able to evaluate this.
All right, so ulnar, heaven forbid, you're looking for the brachial and you get lost and you're diving down deep and you get into the deep posterior musculature. You can injure the ulnar nerve. I think more common would be this very proximal. If you have an ulnar nerve problem, how are you going to know? Say it again. Claw hand. So let's divide it. So motor and sensory. So motor problem.
And sensory, like loss or diminished sensation of the lateral, pinky, and the.
Right. So again, you're looking for kind of one spot and one motor function, right? Because you want to go and do this in 3 seconds. Because Bashara's got another case going, and once you get back in there and we're up the next patient and blah blah blah. So median, we said we're going to check here. Ulnar. We're going to check the pinky, right? The pulp of the pinky. Can you feel that or not? Motor. He's not like this, thank God. He's like this, it's too late. It's just time to call your malpractice coverage guy then. So how are you going to test for a motor? No, not, right? Because again, there's overlap of lots of stuff. We don't want to overlap grip because grip is going to be both median and ulnar, and in fact is also dependent on the radial nerve. So not grip. Not sure. So the intrinsics, so not this, right? This we said is going to be from flexor digitorum superficialis, individual muscle bellies. So intrinsic. So if they can do this, right? If they can tabletop and they can do this, I usually just have them do this. Then the ulnar nerve is okay from the motor function. Okay, so radial, right? So the radial nerve, very unlikely to injure the radial nerve. Heaven forbid you do. Motor. And that's the reason that, so it's the only thing that's going to let you do this, right? So wrist extension, if they can do wrist extension, then their radial nerve is intact, right? And that's also the reason that when you make a grip, your radial nerve has to be intact, because if it's not, you grip and it's going to do like this. So somebody's got a radial nerve palsy, their grip looks like this and it's really weak, right? So for you to grip strongly, you have to hold this back with your wrist extensors, so that then your flexors pull against that and can make a tight grip. It's kind of like one of those karate moves or whatever. If somebody's got you and you can bend their wrist, their grip becomes a lot weaker because they run out of tendon to pull that tighter. So that's why you hold it in an extended position. And sensory. So usually we'll feel back behind in sort of the first web space or right back here on the back of the palm. And sensation there, because the tips of the fingers in the back, the median and ulnar can roll over the tips and have the tip of your fingers be covered by both. So the back of the palm and then wrist extension. Those are kind of the simple ways to test
So
those.
let me go over that because this is real important. And you got 3 nerves: median, ulnar, radial. Each one has motor and sensory. You don't have all day to test this stuff, and so you got to have a system of really doing this. And so what Eric's talking about is the easiest way to say put your hand flat. If you can do that with your thumb. Now you can't do that because that's the forearm the extensors. If you get to put your hand like that and you do this, what's that? Median. That's pure median nerve. What's that? Ulnar. What's that? Radial. Now you've tested all 3 nerves motor. Okay, so it's like it's that, and that. Takes 15 seconds to do this. Sensory. What's that? Median. What's this? What's that? You've done it. You basically have covered almost everything you need to be able to cover at that point in time. So we need you to be able to do a neuro exam basically of your hand. We don't expect you to do nerve conduction velocities to that kind of level, but we do expect you to be able to grossly examine the hand. And when you're doing dialysis access, believe me, you're going to be looking at a lot of hands and trying to figure out what's going on with them.
Not just that, but when you're seeing trauma, when somebody's had a percutaneous intervention, lots of stuff, right? Somebody come back with lots of pain after who knows what, you really want to be able to say that. And then you're going to have to communicate with the hand service, right? And it's not like, I don't know, the hand's just really jacked up and there's something wrong. Come see. You're like, back to med school, figure it out, and then call me. You're like, that could take a while. I got to figure that out. I don't know if your forms will give you all that. All right, so.
B. Brachial. C. What are the branches down there? Radial, ulnar. What's
so
E?
Radial, ulnar, interosseous, sort of the perineal of the arm, right?
Yeah.
Humerus? Yeah. So we're fun to break it.
All right, so
All
you
right.
got them. Yeah.
All right. Axillary artery begins.
First rib.
Where?
First
Outer border first rib. Very good. Where does it end?
The teres major.
Oh my lord. Shocked. Very good. Lower border teres major. What divides the axillary artery into 3 parts? Anatomic. One of the reasons that, first of all, typically the most common area that you're going to expose the axillary artery is you make an incision that's inferior to junction of the middle and lateral third of the clavicle, usually a couple of centimeters below it. Okay? Now again, you're thinking anatomically. So we're going to go down to the axillary artery. We're not teaching anatomy just for the sake of teaching anatomy here. We don't care about anatomy per se. We care about applied anatomy. That's why we're giving you all these illustrations of how things can go wrong and why it's important for you to be able to identify that. So Dr. Bashara's tied up. He says, go ahead and expose the axillary artery for me. Well, you've been an intern for 2 days. He said, but didn't you know anatomy? Didn't you learn any anatomy? Just go ahead and get it out for me. So what are you going to do? Skin. Same process. Skin. Subcutaneous tissue. Fascia. Now you're coming across pec major. What were the 2 parts of pec major that you saw divided in that earlier illustration? 2 parts of pec major. Divided up into clavicular head and sternocostal head. And there really are almost 2 separate parts of the muscle. I mean, ideally you go between those 2 components, but you split the fibers of the pec major. Fibers are running from here to here, okay? You split them. Then you're going to come across pec minor, or the thoracoacromial fascia. Pec minor, you divide. And then you're going to come across the second part of the axillary artery. And in the second part of the axillary artery, where all the cords of the brachial plexus are in their appropriate position. Medial's medial, lateral's lateral, posterior's posterior. And so the brachial plexus is there. You don't want to nail or injure the brachial plexus. So that's how the 3 different parts of the axillary artery are going to be defined. Anyone add?
No, I mean, just real quick, I mean, they were asking about which one is dominant, radial, ulnar. I mean, I know probably you guys never seen it, or we don't do as much, but, they used to harvest the radial artery, right, for cabbages. I mean, if that was the dominant, typically you're not going to harvest the dominant. That's one way to remember. Sometimes you can answer questions by stuff you do in real surgery, so that's how I remember it, So since you harvest the radial artery, obviously the ulnar is the dominant, but you still have to do the Allen test, right, before you stick the radial artery or anything.
We'll cover the Allen test when we're talking about H&P, but it's, again, you're thinking Allen test, you're seeing that anatomy in your mind is how it should work. Okay, now we're going to come down onto the visceral segment. So the aorta, we've got ascending aorta, arch, descending. We'll talk about descending a little bit later. And as it transitions from the chest down into the abdomen, we're going to move into the visceral segment of the abdominal aorta, or the abdominal aorta. And that basically ends at the bifurcation. Where's your bifurcation on surface marking? Do you know? Patients always come with, that's not surface marking. You can't see it. Surface marking, yeah, unless you got a label on yours. Patients will often say, where's my aneurysm, doc? So here, from here to here, belly button's here, xiphoid's here. Where's the aneurysm? Above your belly button. Belly button's typically, most patients, sometimes the belly button's down your knees, is typically the surface marking in a normal 70-kilogram man, basically, of where the bifurcation actually is. Okay? So, again, I'm lost. I gave up in the back row somewhere. Right, you're up. You know, what's your name?
Caitlin.
Caitlin. Okay, Caitlin's got it. I was talking to the other girl, but you got it. You got the ball. What's your name? You already got a question. Okay, Caitlin, you're up. Okay, so again, you're a red cell flying down the descending thoracic aorta. There's the crust of the diaphragm anteriorly. Now what? We're trying to figure out where I'm going. Where can I end up?
The first one you can come off is the celiac.
Celiac artery, L1, T12, L1. When we expose this thing, what's over there? What's anterior to the aorta at this point? We're transitioning from the chest into the abdomen. It would be nice if they're all dissected out like this for you, by the way. Life as a vascular surgeon would be great. Unfortunately, that is this deep in there, and there's something in front of it that I got to move in order to be able to get there. Pardon? Can I hear? Loud and proud?
The duodenum?
Oh, no. It's way down here. Okay, we're just
Oh, we're just at the
what defines the chest and the abdomen? What's separate? The diaphragm. So this is where the diaphragm is. See that thing called median arcuate ligament? So basically we've got the right and left crust. The median arcuate ligament arches over like that. Okay? And it sits on top of this thing like that. Why might that be important? Because every now and again, somebody comes along, they got belly pain, and they refer to you and say, this patient's got median arcuate ligament syndrome. Anybody know what that is? This is an anatomical finding. Anybody heard of it? Okay. So what happens is that this thing sits there, it rises and falls with respiration, and every now and again you'll find that it impinges right on the origin of the celiac artery. And sometimes it's pretty dramatic, and sometimes you get post-aneurysmal dilation of that. Rarely is it symptomatic. You'll be referred 10 patients for every one who probably needs an operation. And so that's a real challenge because there's no specific diagnostic. Anatomically we see it, and the imaging we see it. Sometimes patients have no symptoms at all. This is an incidental finding. They'll be sent to your office. What operation do you do? They're asymptomatic. They come to you. They've got a CT scan because they've got stones in their kidneys, and they go, oh my gosh, got celiac artery compression syndrome. Better send them to the vascular surgeon.
Somehow you have to decompress.
No. Decompress the patient's mind and tell them it's probably irrelevant and it's probably been there for a long time and you don't need to do anything about it. So the overwhelming majority just ignore them. There are plenty collaterals, and we're going to come to that. So it's not a problem of lack of blood supply, okay? But what sometimes happens is these patients have all these vague abdominal pains. They've gone through the multi-million-dollar workup, looked at the gallbladder, looked at the small bowel, looked at the pancreas, and nothing's been found. And then they find this, and that's one of the things that we really agonize over what we should actually do about something like this. And so typically, if we're not sure, the approach is laparoscopically divide this. Because sometimes it's a pain syndrome. It's usually nothing to do with blood supply. Sometimes it's a pain syndrome, a bunch of ganglion in there. Sometimes that alone will relieve the patient's symptoms. If they're still having symptoms, then we think about putting a stent in there. You think 5 times before the one case that you actually go ahead and do it, because most of the time it doesn't help the patient. But that is an option. So this is an anatomical problem from compression from the median arcuate ligament syndrome. Okay? All right, so what are we looking at? What are the branches of the celiac artery? Give us your name again so we can all get, pardon?
Shivani.
Shivani, all right.
Came out the splenic and the common hepatic.
And?
Left
Splenic, common hepatic, left gastric. Left gastric's never really that important. Splenic is moderately important. Hepatic is pretty important. So last week we also did a common hepatic artery aneurysm that actually extended beyond this artery into the common hepatic. What's that?
Right.
Pardon? Hepatic artery propria or true hepatic artery. Typically you can ligate this as long as this artery is patent. What's this one? Gastroduodenal. Gastroduodenal collateralizes to the SMA. We'll show you some of this. This one you really need to reconstruct. Ideally, you need to reconstruct. You can sometimes get away with it, but you really want to kind of reconstruct it, if at all possible. Okay? So there's a lot of variations that can actually take place basically in this particular area. What are they? Tells you what they are down here. What does a replaced right hepatic artery mean? Anybody know?
Comes off the aorta.
It can come off the aorta or it can come off the superior mesenteric artery. And you can get a bunch of variations that can take place basically in the hepatic artery blood supply. Less so and less important basically in the superior mesenteric artery blood supply. But again, this is sometimes very important. For example, if we're going to cover this with a stent graft, for example, then it's helpful if the hepatic artery is coming off the superior mesenteric artery. We may not need to revascularize the celiac. So it's important you can actually identify what these variants, actually are. And when we're still talking about variants, let's move on down. So you're going to have celiac, superior mesenteric artery, and then you've got the renal arteries. Now, one of the more common variants that you're going to see in the abdomen are accessory renal arteries. They're a dime a dozen, quite honestly. And they can come off in a variety of different places. Most often they come off pretty close. Sometimes they can come off from an iliac artery. And why may that be important? Why does it matter to you? Do we care?
You're doing an endograft.
Doing an endograft. So do they communicate inside the kidney? Does it matter if we cover them? Usually not. Okay, usually they're segmental. Sometimes they do, and so. But you got to be prepared to. If that's you got an idea from looking at the angiogram how much a parenchyma it supplies, you're going to lose part of that kidney probably, and it'll infarct if you cover that up. Patient's creatinine is 0.8, no big deal. Patient's creatinine is 2. Not sure you're going to want to do that. What are your options? Any idea? Lots of things that you can do. It's probably unfair me asking you that one. I mean, again, you could land short with a stent graft. Probably can't not enough seals on there. You can operate on. I mean, you can actually do this open, for example, and you can transpose that renal artery back onto a graft. Don't forget open surgery, okay? Our greatest fear is that we develop a generation of people who are afraid of the aorta, actually. And so there are options. There are also situations where you can put in a fenestration in a graft, or you can do in situ fenestration and put side branches into it. I mean, you're not going to do that with a normal creatinine, but you are doing it in other situations. So, renal arteries, okay. Left renal vein. Tell me about the left renal vein.
It goes underneath the superior mesenteric artery.
Okay. It does. Well, that's another one of those anatomical book things that you will almost certainly be irrelevant for the majority of cases, except nutcracker syndrome. We've got our world's expert nutcracker syndrome sitting over here. You want to tell them what nutcracker syndrome is? So what you don't see here is the superior mesenteric artery will be sitting like that. In practice, you're operating here all the time. You never see the superior mesenteric artery, but every now and again.
So, like you said, so usually it runs. So you have a low flow state structure, right? The venous structure, sitting between SMA and you have so these are two pulsatile structures, and also it's not just that. Also depends. So there's actually different way where you can diagnose nutcracker syndrome. Some people even look at the angle of the SMA, right? Some people have like really sharp downward SMA, so that actually will make the angle shorter. They say what's more common in like thin people, the fat pad is not there also to protect it. So there's a lot of things, theories why it happens, but basically it's compression of the left renal vein, and usually these patients present with like left lung pain, hematuria, and they'll have some other some other symptoms, but these are the most two common problems. So how would you diagnose it? venogram. So yeah, you can do venogram. What else can you do during your procedure?
Ultrasound.
What do you mean by ultrasound?
IVUS.
Flow, ultrasound.
IVUS, intravascular, no intravascular ultrasound, IVUS. You've heard of it, seen it? Yeah, IVUS. You can do IVUS. What else? That's pretty good. Because put a catheter and you pull back pressures. Yeah, so you can do that. I mean, usually if you have anything like more than a couple millimeters of mercury in the venous system, that's considered significant. So basically, the way you do it, several things. One is what we do is we put like a partial clamp on the cava, transect it, leave a small piece so you can have enough length on it, oversew the cava, and then basically transpose it. That's called transposition. You transpose it all the way down. So I mean, I'll show you. I have some picture cases of it down. Basically, bring it down. Or what some people do, actually take the whole kidney out and re-implant it, which is it's more extensive. But surprisingly, the more I do of these cases, the more, like I had the most recent case was a lady had young girl, flank pain, hematuria, passing out, headaches. They all went away. How? I have no idea why all went away. I thought it's just a flank pain, but again, it's about educating the patient, talking to the family and the patient, but for some reason, all these symptoms went away, but that's basically it.
All right. So a vascular surgeon never drew this. How do I know? There are certain things missing from this diagram that are very important to us. Left renal vein, okay? So first of all, when you're dissecting out the aorta for an aneurysm or occlusive disease, you're coming up the front of the aorta. The upper limit of your dissection is generally said to be the left renal vein, okay? Let's say the aneurysm keeps going up, and I got to be able to divide the left renal vein. Could I divide this left renal vein? Why? Pardon?
There's no accessory.
No accessory what? Accessory veins? It's not really an accessory renal vein. I mean, the renal vein, so first of all, it's anterior to the aorta. Not always. It may be retroaortic. You usually see that in a CAT scan. That's really good because it doesn't get in the way. We don't even have to divide it. What you got to be careful with then is you put a clamp on like that, and you do that, and you tear a hole in the front of that left renal vein behind the aorta. That's a bad day because it's very difficult to repair that. You got to divide the aorta, rotate it up in order to be able to, and you can lose one heck of a lot of blood out of that. By and large, we're a lot more afraid of big venous bleeding than big arterial bleeding, because when the aorta bleeds, it goes. You can see where the bleeding's coming from. You can grab it. You tear a hole in the inferior vena cava or this, there's so much blood coming out of it, you can't suck it fast enough. And so you start jamming things in there. It's so flimsy, you tend to tear it and make it worse. You start sticking clamps in there blindly, you tend to make it worse. So it's we're a lot more afraid of big renal vein or big venous bleeding than arterial bleeding. Okay, let's assume it's anterior. So it could be a collar, could be anterior and posterior. If you see a really small anterior renal veins, because the big vein is going posterior. If you see no anterior one, there's a big one going posterior. Okay, what's missing off this? The suprarenal vein, okay? Right here. There's a big branch that goes superiorly. What else is missing? The gonadal. Gonadal should be coming down here. So as a general rule, you divide this as long as the suprarenal vein and the gonadals are intact, you won't have any problem. And then you can oversew this and open it up, and you're looking right at the neck of the aorta, okay? So that's an important thing. Renal vein, think it's trivial, it's not trivial. We're working around that space basically all the time. Superior mesenteric artery is coming off here. You're by and large behind that. It's not like in the anatomy the superior mesenteric artery is lying in your face. It's not, because somebody mentioned the duodenum. The duodenum is coming around like this. First thing you do is divide the peritoneum. You mobilize the duodenum. It takes the superior mesenteric artery with it. So we usually don't see this very easily at all. And this looks low here. Remember what we said, the aorta divides here? We're up here. We're at the margins of what we can expose here very frequently. And so this is an area that you approach with a little bit of trepidation, because you don't have an easy out if there's a problem that you generate in this particular area. Right renal artery. Who wants it? Back to the front. Travis. Right renal artery. You're a red cell going down the right renal artery.
Right.
Come off the aorta.
And posteriorly to the vena cava.
Okay, so I'm looking and directly anterior is the inferior vena cava. So you're really running posterior at this point. You're wrapping around the side of the vertebral column in order to get out to the renal artery. And in order to expose that, you either got to mobilize the cava. Renal arteries are usually above this, okay? So it's not like the renal arteries are here. That would be really convenient for us. But the renal arteries are usually superior to where that vein is coming off. How am I going to get here, okay? So you got to mobilize this. You got to mobilize this. This is where you don't want to make a hole. You don't want to make a hole right in the confluence of these two things in order to get that. But we can mobilize it to the point that if we're going to do an aortorenal bypass, we originate a graft down here. You clamp the renal artery, oversew this little stump, rotates the renal artery down, and then you can do an end-to-end anastomosis. Same thing can be done kind of on the left side. And then most of these are end arteries. There is some communication basically at cortical level, but again, this is showing. One of the radiologists at Emory always taught me that the artery divides in an anterior and posterior segment. Almost never do you just see it sitting like this. Usually it's like that. If you see it pretty clean, usually means part of the renal artery is actually missing. And this is where you can perforate with these guide wires. Guide wire comes up from the groin, goes out through that, and goes straight out really through that cortex. So we will be working out here for fibromuscular dysplasia. Renal artery aneurysms can be out here. Renal artery stenoses basically occur at the origins of the renal arteries. Sometimes you're going to get involved with renal cancers. The renal cancers grow along these veins and up the inferior vena cava. It may be here, in which case pretty easy. It may be up to here, still pretty easy because you can get below the level of the liver. It goes up behind the liver and starts going up into the right atrium, and it becomes a lot more challenging.